This is an extremely high myopic eye with an axial length of 34 millimeters. The calculated IOL power is -5 diopters, and the cataract is relatively soft. Eyes with such a long axial length present many surgical challenges. The anterior chamber is often very deep. The posterior capsule may be more mobile, and anterior chamber instability can occur throughout the procedure. So the goal is not only to remove the cataract safely, but also to minimize vitreoretinal traction and maintain a stable anterior chamber at all times. After creating the capsular axis, hydrodissection is performed gently, followed by hydrodelineation. As you can see, the golden ring confirms successful hydrodelineation. Because the nucleus is soft, extensive hydrodissection or aggressive nucleus rotation is unnecessary. One important pearl in these eyes is fluidic management. Because the anterior chamber is already very deep, excessive infusion pressure may further deepen the chamber, increase posterior capsule mobility, and make surgical maneuvers less predictable. So for this reason, we prefer relatively low bottle height, moderate vacuum settings, and controlled aspiration parameters throughout the procedure. The phacoemulsification of this soft nucleus is performed mainly by aspiration with minimal ultrasound energy. So another important point is to remain constantly aware of the posterior capsule, because in highly myopic eyes, the posterior capsule may be more mobile than usual. So gentle maneuvers, stable fluidics, and working within the capsular bag help minimize vitreoretinal traction and improve surgical safety. Cortical removal is then completed using careful centripetal aspiration while avoiding unnecessary stress on the zone walls. In this case, the calculated IOL power was -5 diopters. However, we elected to implant a -4 diopter lens rather than targeting complete emmetropia, because in eyes with extreme axial myopia, refractive predictability is often less accurate. For this reason, many surgeons prefer to leave a small amount of residual myopia rather than aiming for absolute plano. Also, residual myopia is generally better tolerated by these patients and reduces the risk of an undesirable postoperative hyperopic outcome. The IOL is implanted in the capsular bag. Finally, the viscoelastic is removed, including the viscoelastic trapped behind the IOL. This step should be performed carefully to maintain chamber stability and avoid unnecessary traction. The wounds are hydrated, and we confirm a stable anterior chamber and well-centered IOL. That makes it a successful day. Thank you for watching.